Good evening. Can everyone hear me? Okay. After two people who are really experts in this area, I am a physician and an architect, but I cover many other areas besides services for aging. But it is something I've been very interested in over the last few years, and I'm going to take you through some of my experience and then take you through some of the issues that you've heard addressed here and how we're going to respond to those in the design of the new hospital for Stanford. The future isn't what it used to be. The future is certainly changing, and actually patients are changing. As you've seen in the slides that Rita was presenting, we have a different patient population than we have ever had before. So we're designing for a different group of people than they were in the past. So our average patient, let's sort of establish who an average patient might be. That average patient is probably a woman. That woman is probably 70 years old is our average patient. So we are not designing for a younger group of people, but this is where our average is right now, and it's going to become more so with the continuing aging of the baby boom. I think in Rita's slide you saw this lovely little bulge that's sitting in the middle of age groups. Well, that's all of us. So I have a prototypical aged or elderly patient that I use in looking at these issues. And there she is. This is actually a picture from 3 years ago, so I apologize. Jane Fonda is even older than 70. But this is a different patient than we have ever had before. And this is a different group that we have to design for. I showed this slide in Chicago 3 years ago and at a meeting, and people said, well, why Jane? And I said, well, why not? I think she's someone who has followed many of us over the years from our very young ages to middle ages and on. And the next day when I gave that presentation to the community, the front page of the Chicago Tribune said that Jane Fonda had a hip transplant or a hip replacement that day. So I was quite pleased with my choice here. But it also talks about the difference between two groups of aging patients. This may be what we call the younger aging patient. But then there's the other group. This is Dr. Michael DeBakey, who passed away last year. But this is Dr. DeBakey at 98 in the operating room. Really an example of what people are doing and continuing to work and be vibrant to very, very older age. I'm living with this now with my 94-year-old mother who still drives and does everything else she ever did before. This is the group that does very, very well until they become sick. And then there's a very big change in how they adapt, how they can respond to medication, surgical issues, etc. And these two groups, the 70-year-olds and the 90-plus-year-olds, are very, very different people to design for and to plan for. And we have to look at both of these groups and how we respond. But we are operating on many people in their 90s now. Winston Churchill said this very famous statement for the architects in the audience that we shape our buildings and afterwards our buildings shape us. What that means is as we plan our design, once that is built, it will impact how care is given. So it's very important in the planning process to understand what we can do in creating environments that will assist in the care of patients and also assist in serving those who serve those patients. The average age of nurses in the United States right now is in the low 50s. The people who are taking care of the elderly aren't that young either. So we have to provide environments that assist them in the care of these patients. So what do? The other piece that's really critical is that we provide in a design process what we call surrogate evidence. You can't see everything that's done in your care process. You really can't go in to the operating room ahead of time and make sure it's clean, and make sure that the people there are well qualified. So our environments are your clue to the quality of care we give. So as the same thing in a hotel, as you come in and you see, are the plants as you enter still alive? our environment as you enter the hospital campus better look like we can keep our landscape alive, because you're the other thing we're caring for. So we have to plan that environment, our buildings, our furnishings, the color, the signage. If you can't read the signs we present, that means that we're not designing them for you, are we? So these are things that really matter in how you perceive that you are getting good quality care and that you feel comfortable in that environment. Betsy mentioned again the issue of ecological health, the connection to nature, and eliminating environmental stressors through having outdoor environments and being able to see nature. You'll see in the planning of the building is really focused around an outdoor space, a courtyard that orients the entire facility so that nature is what orients people and makes them comfortable within this environment. And why are we doing this now? Well, there's a number of reasons. Many of you who've been to the current hospital, which Shelley mentioned was built in the Eisenhower administration, our building is becoming a geriatric patient. Many of you, at my home, we have a kitchen that was built in 1955. It is really time to change that kitchen. The same thing's true with our operating rooms today, our patient rooms with 2 to 3 patients in the rooms, antiquated head wall systems, rooms that are just too small for the services we're providing now. And newer environments provide those safer environments for care, and we now have evidence that the environment has huge impacts in patient outcomes from medical care. It also is in healthcare around the country, not just in California. There is a construction boom related to hospitals because the last time we had real major national initiatives for developing hospital facilities was back in the Eisenhower administration, and those buildings are about 50 years old, and it is time to replace those buildings. We have a population that's different than those buildings were planned for as we set our aging population. We have bed shortages in most hospitals, including Stanford, and there's been a real push and evidence now that we provide better care in single patient rooms. They are safer for patients, they decrease infection, they allow family members to sleep in, which has a huge impact in safety and outcomes for patients, and these kind of things can only happen in single room environments. And that means that our hospitals are almost doubling in size because we're going from double patient rooms to single rooms. And that's why when people hear it's 1 million square feet, why do you need that much more room? It's because we need more room for single patients, as well as larger operating rooms and more support spaces. The other issues are financial impacts. Good quality hospitals reduce falls, they reduce patient transfers, they reduce nosocomial or infections you get within the hospital. So many people come into the hospital relatively healthy and don't leave that way. They get infections at the hospital. It reduces drug costs because we're not medicating patients as much with better designed facilities. It reduces nursing turnover because we have less injuries from nurses moving patients, etc. It increases market share for the hospitals because people come to nicer hospital facilities. Hate to admit that's true, but just like anywhere else, people try out the better facilities. And it increases philanthropy. People will donate money to hospitals when they know that they're seeing actual impact in the facility as it's being developed. So let's talk a little bit about what's going on at Stanford. We are planning 2 new hospital facilities, a major facility for the adult hospital, Stanford Hospital and Clinics, and medical office space up at the Hoover Pavilion site. This is all part of the development agreement that is now being negotiated with the city of Palo Alto. The expansion for the hospital itself, the new hospital, is slightly under 1 million square feet and up to 450 beds in the new facility. Some of the existing facilities, which were built in the 1980s, will remain. There will be beds in those units so that the hospital will have an overall capacity of about 600 beds.